Hello, everyone, and welcome to the IOCDF Research Roundtable, the live stream where we pick an interesting part of the OCD research world and discuss it with the people who know it best. My name is Kyle King. I'm a rising senior at Yale University studying neuroscience, and I research a lot of OCD within the OCD Research Clinic. And OCD is really near and dear to my heart, not just because I find it like an interesting disorder, but also because I have it. So a lot of the research about it pertains to me, and yeah, it pertains to me. And as always, I'm joined by my co-host, Jon Abramowitz. Jon, if you want to introduce yourself.
Sure, I'm Jon Abramowitz, and I'm a professor at the University of North Carolina at Chapel Hill, and I love studying OCD and treating folks who have it and training the psychologists of tomorrow to treat OCD. I don't have OCD, but I am fascinated by it and am always learning more.
Jon, you always have a guitar in your background, and I wanted to feel as cool as you are, so I also have a guitar in my background in this show.
You're stepping up. Wayne, are you?
Yeah, Wayne, do you have guitars? I just try to look.
No.
Okay.
You seem to have everything else in your background.
A nice view of Houston.
Yeah.
As you can see, we have two guests on the show today. But before I introduce them, I do have a couple things that I must say. So let me go over to the announcements. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact the local clinician. You can use the IOCDS online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in a crisis or ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. Also, just so you know, we have a comment section and a chat feature. We love when you put questions in the chat, and we'll try to get to as many as we can. And but everything that you put in there will live online forever. This is live, so you can't take anything back that you put in there. So please just be mindful of that. And we want to make this as comforting and as caring a community space as possible. So just be mindful of what you put in the comment section. And so today we're going to be discussing the Y-Bocs, which is something that I've really been looking forward to talking about because I remember taking it when I was 13. And when I was 13, I could barely leave my room because my OCD was so debilitating. And I scored, I think, like a 15 on the Y-Bocs because I just completely lied. And ever since then, the Y-Bocs has been something that's been interesting to me and my parents because we didn't really understand it. And the questions have always been kind of complicated for me to answer. And we have two really good people to talk about the Y-Bocs with today. So I will start with introducing Wayne Goodman, who's in my upper left. Wayne Goodman is the Irene Elwood Professor and Chair of the Department of Psychiatry and Behavioral Science at Baylor College of Medicine, specializing in OCD and deep brain stimulation for intractable psychiatric illness. He is a principal developer of the Y-Bocs and the gold standard for assessing OCD and the co-founder of the IOCDF. Prior to joining Baylor, he was a senior administrative positions at Mount Sinai Hospital in New York, the NIMH, and the University of Florida. He graduated from Columbia University with a degree in electrical engineering, although he did not have to take multivariable calculus, which I just learned, and received his medical degree from Boston University School of Medicine, and completed his internship, residency, and research fellowship at the Yale School of Medicine, where he remained on faculty for 7 years. Wayne, we were talking about the heat in Houston earlier. What's your favorite summertime activity?
Jogging.
Jogging, all right.
In the morning.
Okay, yeah, before it gets sweltering. Our other guest is Dean McKay. Dean McKay is a professor of psychology at Fordham University and the chief clinical science officer for the Better Living Center for Behavioral Health. He is past president of the Society for the Science of Clinical Psychology and the Association for Behavioral and Cognitive Therapies. He has co-edited 22 books and published over 350 journal articles and book chapters. Dr. McKay is a licensed psychologist in New York and Connecticut and board certified for the American Board of Professional Psychology in both cognitive behavioral and clinical psychology. Dean, you really want to mess up my tongue with his bio. His expertise is in anxiety disorders, OCD, and the role of disgust in psychopathology. Dean, what's your favorite summertime activity?
Well, I'm up in Massachusetts now, where bicycling is great. It is a little toasty up here, not like Houston, but getting out to bike at daybreak is probably one of my favorite activities.
Yeah, when you say it's a little toasty in Massachusetts, you better watch it. You're with a Texan.
I know. Yeah, it's high 70s here. Right?
Oh, come on, give me a
That's
break.
Yeah, so
That's nice.
yeah, it's nice. Yeah.
John, I didn't even ask you. What's your favorite summertime activity?
You know, I play actually a bunch of sports outside. So like softball, baseball, I would say that'd be my go-to. But I also like running, jogging, like Wayne.
I can't run. I get too bored.
Put on some music and away you go.
Okay, but enough of this funny business. Let's get on to the meat of it. Today we want to talk about the Y-Bocs. So I want to pitch it to Dean and Wayne first. What is the Y-Bocs?
So the Y-Bocs stands for the Yale-Brown Obsessive Compulsive Scale. And I worked on developing that with my colleagues at Yale and Brown, hence the name, when I was at Yale. So I started the OCD program at Yale in the 1980s and developed the Y-Bocs in the 1980s. And the impetus for that is we were starting to conduct clinical trials of medications for OCD. And that included, at that time, the SSRI fluvoxamine, which we had research access to. And there was also the clomipramine, or Nafrano trial. And so there was a bit of a competition which rating scale they were going to use and which rating scale the FDA was going to honor as the outcome measure. And we won that contest back then.
And when you said it's the obsessive compulsive scale, what is it specifically measuring?
So again, going back to kind of the origins of it, at the time we were developing most of the Y-Bocs, most of the other scales were really inventories. And one of the disadvantages of inventories for measuring severity and comparing patients is if say that you have a number of items that are related to cleaning and washing, you're going to get a high score. Whereas if you have more of a monosymptomatic picture, whereas maybe it's not just, but it's involved with scrupulosity, taboo thoughts, but you don't endorse a number of different items, may look like you have less severe OCD. Mm-hmm. So what we decided to do was develop a scale that had two parts. The first part being an inventory of symptoms, so that we get we can confirm with the patient what are the obsessions, what are the compulsions, what's the avoidance, so we make sure that we're on the same page. And then we measure severity that's independent of the content of the person's OCD. Mm-hmm. So we look at how much distress they cause, how much time they consume, how much they interfere with functioning, and how much they can control them.
Wayne, I got a quick question. What was the other? I didn't know this that you had to. What was the other possible measure that was going to be used in those trials?
There were several contestants.
Okay.
So we happened to have more data. So we had actually we collected psychometric data on 40 patients at around the time the FDA was making its decision about which scale to use as the outcome. Again, one of the other impetus was here we are about to conduct pivotal trials of drugs that are antidepressants. I mean, like clomipramine is still an antidepressant, fluvoxamine. Mm-hmm. Well, not a very good antidepressant, but it's an antidepressant. So we needed to have a scale that was specific to OCD and really wasn't just another measure of depression. Otherwise, the FDA would say, well, you're just measuring depression. So we want something that was specific to OCD.
I think it's worth kind of jumping in for a second. One of the things, Wayne, that I think was an important advance with the Y-Bocs is that it was the original version that you developed was a clinician-administered scale. And there was always before that a preponderance of self-report measures that you would just hand to somebody to fill out. And the clinician-administered model has some benefits in that clinicians get a chance to ask a couple of follow-up questions to get some certainty that the ratings represent what the client intends. Is that an accurate
very much
idea to add to how, like, the origin story of the Y-Bocs?
Yeah. I mean, you're still depending in large part on what the patient reports to you, but the more experience you have with OCD and more experience you have with the Y-Bocs, you get a sense of the range of severity. So one patient can say, "How distressing are the symptoms?" And they may just say, "Moderately so." And somebody's moderate may be somebody else's severe or mild. So it's really the scoring is up to the clinician based upon all sources of information, including your own experience.
But it follows a tradition in other areas of psychiatry with respect to clinician-administered scales, and not leaving it up to the client to interpret what the intent of the question is. I think, right?
I completely agree.
Yeah.
I mean, since we're on the topic, I do want to kind of get back to the genesis of the Y-Bocs eventually. But like, Dean, when you're administering the Y-Bocs, to what extent do you kind of take the patient's word at face? Like, how do you determine when I'm the clinician and I'm going to step in and say, like, no, maybe you're underreporting your symptoms here. Maybe you're overreporting your symptoms here. Like,
Well, there is the role of clinical judgment, I think, is always present when there's a clinician rating as well as any intervention. And there are occasions where it's worth asking the follow-up question that might include something where the client is just simply overlooking the full scope of how much the symptoms are impacting their lives. So the reference point is to the checklist that Wayne was mentioning that accompanies the Y-Bocs. So you have the symptom checklist, and it has categories of symptoms that are fairly typical for OCD sufferers, and it's pretty diverse range. And if somebody has a variety of symptoms, and then I'm asking them, let's say question 1, how much time in a day do your obsessions occupy you? And they say like an hour a day. I might say, oh, well, on your checklist, you have a lot of things here. Let's kind of think about that for a second. Is it only an hour? And maybe it is, but it's worth asking in a way that allows for a fuller recollection and basically inviting the client to do a little bit of an inventory of what their daily life looks like. Because in the moment that they're sitting before you, they might be thinking like, I just came off a bad bout of checking. And they've overlooked the fact that just the day before or that morning, they were also really stuck washing a lot, or they had a whole litany of intrusive, blasphemous thoughts. And those just get kind of overshadowed by what was the most current thing. So at least I think, and maybe there's a difference in how different professions may probe these things, but at least for me as a psychologist, I'm aware of the concept of recency. And so the things that happened most recently are what you most remember. But there's a whole bunch of other stuff that's probably very significant that if I caught you at a different moment, that would be more prominent. Right. And so that's how, at least from my perspective and how I've been inclined to train people to administer the Y-Boc, that's the viewpoint that I come at it from.
And John, the other psychologist here, do you concur?
Yeah, I completely agree. And, I just think in any sort of assessment, you want to get multiple types of data. So, it's good to have a clinician interview, and it's good to have self-report, and you'd like to see that those things somewhat are correlated. If someone is taking a measure, a self-report measure, and they're just, everything is really high, and then you give them an interview and everything is kind of low, like, what's going on? And we might discuss that. But I completely agree.
Yeah, and also you can include information from informants. It could be it could be a spouse, it could be parents. The only caveat there is when you're actually conducting a clinical trial, like a research study, whether it's a behavior therapy of a device or a drug, you just have to be consistent from session to session, because if you just invite in the parents on one occasion, they tell you my son's not telling you all this stuff that he's doing, then you're going to have a bump in the score, and then the next time they're not there, it's going to look like it went down. Yep. So you just have to be very consistent in how you use information from other sources.
My parents tend to be more honest about my OCD than I was. Yeah.
Well, you're raising a great point here, and you foreshadowed it a bit, Kyle, and that was when you were younger and you took the Y-Bocs. I imagine you took the children's version. And so, there is I guess an alternate, there's a kid's version of the Y-Bocs that was developed When was it, Wayne? I guess in 90s.
It was around the same time. It was.
Oh, it was? Okay.
Late 80s.
Yeah, and the criteria from the DSM standpoint for OCD, so separate and apart from the Y-Bocs, is that it's not a requirement that the child have, shall we say, insight. Most kids, and up till when they're teens, they may have symptoms where the necessity of the symptoms is considered acceptable for the kid to say that I have to do this because of the dire consequences. Whereas in adults, the most typical profile is one where the individual says, I feel the drive to do this behavior, but I recognize that it's not going to alter the outcome of what I'm thinking. And so I think a good clinician who administers the children's Y-Bocs should be able to detect this and understand that more so than in adults, you need another informant because observations are going to matter more than what the kid might report.
Okay. And kind of piggybacking on the other conversation we were having about kind of clinician intervention when people are answering the Y-Bocs and determining the score on individual items, is there, Wayne, I feel like this is a good question for you. Is there kind of like a fear that if different clinicians kind of press differently on different items, then like the tool itself will lose its validity because different clinicians are administering it differently?
Right. So again, going back to the scenario where it's a rigorous clinical trial, that would be controlled for. You would make sure that all the raters are trained, and you try to minimize changes between raters, so you get more consistency. But it's a very valid point.
Yeah. So we're doing a study right now with Eric Storch, is a colleague of Wayne's, and is kind of he's the guy that trains all of our assessors in the study on how to use the Y-Bocs and other measures as well. And so in research, Kyle, to your question, the assessors who are assessing folks in the study, they meet weekly with Eric, and they go over their assessments and they record them, and to make sure that everyone is asking the questions the right way and interpreting. Sometimes people will say all sorts of different things in response to the prompts, and there's got to be training on how do you rate that? Is it a 2 or a 3? And so lots has been written and on like, how do you rate different responses that people have on the Y-Bocs?
Mm-hmm. And I guess the concern of like reliability is more of like a research concern than it is like, Dean, if you're in your private practice.
Definitely.
Oh yeah. And in a private practice setting, I mean, it's a useful tool to give people a marker of change in their symptoms. And also the checklist is helpful because, sometimes people do great and improve on one symptom, and then suddenly it reveals that, oh, you know what, I hadn't really been paying attention to this, but it turns out, this other symptom has always been present. And now that all of these other things that I came in for initially have been diminished, this is also now rising in prominence. And so you can make that shift, and it's just that the scores for the Y-Bocs are anchored to a different set of questions on the checklist.
Mm-hmm. Okay, switching gears now to the... Well, actually, no. I want to go back to the genesis for 1 second. So, Wayne, there's 10 items on this scale that's supposed to measure OCD severity. How did you boil down, like, determining how bad someone's OCD is just to 10 questions? Like, how did you pick these questions?
So it was based on combined clinical experience. So it was remembering back to the time that I was working on it, although I had a full-time job at Yale, I basically spent 6 months just seeing as many patients as I could, and testing out different questions and trying to, for example, on the symptom checklist, trying to say what are the broad categories, and trying to narrow that down, and we had lots of discussions. The principal developers were Larry Price, Steve Rasmussen, and me. And Eric Storch, who was mentioned, has been very involved later, particularly in the development of other versions of the scale, including the Y-Bocs 2, which maybe we could talk about at some point.
Oh, we'll get to it.
Yeah, but Yeah, I probably although there are 10 items, I like symmetry. So we had 5 items for obsessions, 5 analogous items for compulsions. The Y-Bocs 2 is a little different in that way. We'll get to that later. But so what we're looking at is we go through, identify what we agree upon with the patient, what are their current symptoms, what are the ones that are kind of most disturbing. If I were to pick one item, it would be time.
Huh. Interesting.
I mean, and the other items are important, and when we've demonstrated that. But I'm at the point where I prefer others administer the Y-Bocs than me. So if I'm sitting with a patient doing an evaluation, I may go through the symptom checklist, or if I don't have a lot of time, I'll get a sense of how much time they're spending. And there's another item in there that it's funny. It's considered an experimental item 30 years later. So one of the things we found early on is when you ask how much time do you spend, performing compulsions, how much time do you have, thoughts of obsessions, it could be hard because, it's very hard for people to add that up. How do I do that? So the alternate way of asking that question is, how can you go without having an obsession? How long can you go without feeling a need to perform a compulsion? And that's another way of getting at time spent. And then the other things like, and then if you're spending less time performing compulsions or having intrusive thoughts, then, it makes sense. It's going to be correlated with the decrease in interference, the decrease in distress, which are the other items. And probably you have more control.
Mm-hmm. John, why did you say interesting when you said time is?
Oh, I'm curious to hear, Wayne developed this measure that really is like, that's when I was in grad school and internship, the Y-Bocs. And it's just kind of really, I'm a nerd about all this stuff. It's kind of cool to hear from the guy that developed the Y-Bocs and hear his thoughts about the scale. So I'm just kind of geeking out. So I worked in Edna Foa's clinic for 3-4 years, and it was we learned, I slept and had dreams about what's the Y-Bocs of your patient. She would say, when we would have supervision for studies, she would say, what's their Y-Bocs, and without even giving the Y-Bocs, we would kind of learn how to time, interference, distress, resistance, control. See, I know by heart, and you kind of learn how to come up with those, with a good guess, of what the person probably is. So I think in terms of Y-Bocs.
So it's fun. I'm glad to hear you say this about Edna. She was actually my harshest critic when I first introduced the Y-Bocs. This was at an investigators meeting of the original clomipramine trial.
Yeah,
she picked it apart.
No,
so I'm glad to see eventually she adopted it.
Look, she's a critical thinker, but definitely. And I think, in part just because that's what, to be relevant, that's what everybody uses. And if you're going to be able to compare your results with other studies, drug trials, behavior therapy trials, everyone thinks in terms of the Y-Bocs. That's the thing. And I know there have been other criticisms and people have tried to develop other scales. They don't take off because everyone is using the Y-Bocs. So it's kind of cool to hear Wayne talk about that.
Well, first of all, John, you sound like you were super fun in college. And
thanks, Kyle.
Wayne, I don't mean to dredge up bad memories, but I feel like it's probably instructive. What were Edna and what are some other criticisms of the Y-Bocs?
I don't remember at the time. All I remember is feeling attacked in a public forum. But I got over it.
Well, I mean, do you see any disadvantages to this particular metric? You made a second one, so I feel like there must be some.
Well, there are. We could certainly get to that. The only other thing I just wanted to mention, I don't know if we'll get to, what I've found over the years is that particularly patients that haven't been formally diagnosed with OCD yet, and I'm evaluating them or somebody else is evaluating them and using the Y-Bocs, some of these patients are very much reassured because you go through this comprehensive checklist. I mean, that's what takes a lot of time in that first session.
Yeah.
And you go through all these different examples, and some of them, like, no, I don't have that. And then, yeah, I do. I mean, other people have that. I thought I was the only one.
Absolutely.
Yeah.
And so it actually forms a kind of a therapeutic alliance early on. I had that experience recently with a patient who had both tics and OCD, and I've done a little bit of work on kind of the symptoms are a little bit different in those Tourettic OCD cases. And I started asking her questions about, and she said, nobody ever asked me about that before, but yeah, I have that need. I have to, when I have a tic on the right side, I have to balance it with a compulsion on the left side.
Oh yeah.
Yeah. So, or I have to even up things. If my shoelaces aren't tight enough on the right, I have to make them the same on the left.
Yeah.
So little things like that you do during the course of the initial administration can actually create a very strong bond with the patient and make them feel that they're working with somebody who understands their disorder.
Very much.
I like to focus on the negatives. So are there any questions on the Y-Bocs that are particularly hard for patients to oftentimes answer? And there's a lot of clinicians that watch this show. So like, do you guys have any common ways of phrasing them?
Dean, I'll let you talk about item 4.
Yeah, I have item 4 on my notes. It's hard for me to answer.
Well, yeah. So the resistance to obsessions question has been of concern. And I think probably the clearest way to explain this is that resistance to obsessions is scored based upon whether or not the person gives in to their obsessions. And so let's say prior to treatment, someone may be giving in to their obsessions, for lack of a better way of putting it, and that would then lead to you getting a high score. Mm-hmm. The conflict is that a client could come in and get rated on that measure, and they've previously had certain forms of behavior therapy where, as part of exposure, you're asked to allow the obsession to kind of roll over you, and it would maybe be interpreted as giving in. And someone could score high on it, even though the other items they score low on because they've done well in behavior thancy. And so the resistance question has some confusion built into it. It's actually the one that in factor analysis. So we'll wonk out for a second. For those of you clinicians who are not so statistically minded and any clients watching, there's a statistical procedure that's conducted where you look to see whether or not questions that are part of a subscale stick together the way that people think it's supposed to. And each item, we would say, contributes to that little subscale to a certain amount. The resistance item in factor analyses always comes out the lowest. So it's a difficult question to administer. It's a difficult question for clients to respond to, and it's a difficult one to really interpret.
And that's the longest instructions to the clinician about how to administer.
Oh, yeah, right. You devote a lot of time to it. There is one other thing, I guess. Well, go ahead. Let's round out on the thing. I
just want to make sure, because the statistics are the most confusing part to me. When you say it comes out the lowest on these factor analysis, that just means it doesn't what does that mean? I can't even.
So the way that we think of it is, let's say you have a bunch of items that are part of a scale. Mm-hmm. Those items that contribute to the scale, there's a certain amount of it where you say, this is truly representative of the scale. There's some portion of it, like if you put a Venn diagram together, you'd say, look how much it overlaps with this concept. The resistance item has the smallest overlap with that concept. And how
do you measure resistance to get the amount of overlap that this item has? Like, what reliable metric of resistance do you have to check the Y-Bocs against?
It's only itself. It's basically how much does it correlate with all the other items.
So you would do you would administer the scale in a number of different subjects and see how much each of the items correlates with the other items in the scale.
Right. So this is the kind of thing that you can only learn after you've given it to a large pool of individuals with OCD. Yeah. Mm-hmm. And you find that item just doesn't correspond that well to it. There's a lot of what we call like error. There's a lot of stuff that's like noise in that item. That's all that it is.
Now there is another resistance item that I think works pretty well, the one on compulsions.
Yeah. Oh, the compulsions one is actually
it-
much better. Yeah.
Yeah,
Consistently. Yeah.
Yeah,
Mhm.
but that one's consistent with the instructions you would receive if you went through ERP.
Right. Exactly. Right.
Yeah.
And my excuse is I didn't know very much about ERP back in the
So
80s.
in the 80s, right? I mean,
Most people didn't.
That's right. The conceptualization, I don't hold that against the developers of the
Right.
web.
Absolutely.
Now and like we didn't have the theories that we have now
Yeah.
about like you actually don't want to be resisting
Right.
obsession. So I think it makes sense,
Yeah.
in the context of when it was developed.
As a historical analysis,
Right.
right? The Y-Bocs came out 3 years after FOA talked about the concept that undergirded why exposure would work. So this was definitely not mainstream behavior therapy practice at the time. So most people really didn't know. And in fact, if you were in certain parts of the country, if you're doing exposure therapy, you're being accused of being unethical. So
Really?
I got my degree in '93. Routinely was accused of being unethical.
Because
for doing
you're
exposure
making people more anxious?
Yeah. The prevailing sentiment in psychology at the time was like, you're not supposed to make people anxious in a therapy room. That's bad for the client. It's
interesting.
bad for your relationship with them. Everything, it was all basically like, you're not supposed to do that. Thou shalt not.
There's still people who think that way, by the way.
Yeah, if you're in the New York
Only
area,
out.
there are a lot of people who are like, yeah, no, you can't
Oh,
do
yeah.
that. That's bad. And the psychoanalytic theory was like, if you provoke anxiety like that, you might cause people to be psychotic.
Yeah.
That was where I was accused of being unethical.
Well, my therapist certainly didn't buy into that.
No,
She made me
and most
very
people
angry.
don't anymore, by the way. A lot of people don't anymore. Like we're long past it. That's also like a little historical note.
I did have a question about force though. So like you said it measures the extent to which you kind of give in to these obsessions, but that sounds really similar to item 5 to me, which is like control over your obsessions.
Well, so what's different about control is the perception that one has that they can manage it effectively, right? So the resistance question, this is where one doesn't relate well to the other. So if someone had effective behavior therapy and they answer item 4 in the direction of, I don't resist the obsessions, but they've had effective behavior therapy, on number 5, they would go, oh, I have great control.
Okay.
Whereas someone who's never had treatment might say, yeah, my obsessions run roughshod over me. I don't have the strength to fight them. They score high on resistance. How much control do you have? None. Now they've scored high on 4 and 5.
Mm-hmm. So
You know
what
the
is
scale better than I do, Dean.
Pardon me?
Obviously you administer it more than I do.
All right, Wayne, you know what? Why don't we meet later? I could work on your reliability. Yeah, we have a little training session.
Talk to Eric.
Yeah, we're gonna have to have a little seminar.
So in 2010, Eric Storch, who we talked about, helped me do a revision of the Y-Bocs that included discarding item 4 and replacing it with distress related to obsessions.
okay?
And
So
there are a few
not
other
just
things
trouble.
we did, but I don't know if we wanted to talk about it or not.
The Y-Bocs 2? Is that a
There's
reference
a
to ours?
Y-Bocs 2. It's been out there for 13 years. Not really that well adopted, even though we really went out of our way to make it easy to convert to the original Y-Bocs, because I think Dean alluded to this earlier. So if you've got a new form of CBT or a new medication, and you want to compare the results to previous trials, you want to be able to convert it to the original Y-Bocs.
Right.
So there you can do that.
Mhm.
But it's a different scale range. So the original Y-Bocs goes from 0 to 40, where 40 would be the most extreme symptoms, 0 would be none. The Y-Bocs 2 goes from 0 to 50. And actually the main reason, well, that was one of the reasons we wanted to do something about this item 4. But also in the last 15 years or so, I've been doing a lot of work with very, very severely treatment-resistant OCD and doing deep brain stimulation. So their scores on the original Y-Bocs are generally like 35 to 40. And then they might, we were noticing they might getting a little bit better, but the Y-Bocs wasn't picking it up. So we added some sensitivity at the upper end.
Okay. Well, now that we started talking about the Y-Bocs too, let's do it. So I have a couple questions about the Y-Bocs too. First, how did you add the sensitivity?
So what we did is we basically, and Dean, I may call on you. I don't remember that. Time may be a good way of doing it, so that amount of time spent on obsessions, it would be the high score in the Y-Bocs 2 would be, is it greater than 8 hours a day?
Well, that was on the original Y-Bocs, I think.
Yeah, greater than 8 hours.
Kind of a blanket
yeah, that sounds
statement.
right.
Yeah, sounds right.
A rating of 4 would be 8 hours or more.
But imagine you're doing it 16 hours a day,
right,
every waking minute, which is true for many, not many, but certainly not some patients.
Yeah.
And then you go from 16 to 12.
Yeah, that's an improvement.
That's an improvement.
Yeah.
But the Y-Bocs 1 wouldn't pick it up.
Right. So what Wayne is referring to in the world of psychometrics, they call this a ceiling effect. So some measures have, shall we say, a low ceiling, where you can't get above a certain. You get to a certain score, and it doesn't detect greater severity than that score, and so that's how you get more sensitive. You increase the boundary for what a high score means, which is an important thing to do, especially as you get to understand. Like, I imagine when you develop the scale, Wayne, it'd be pretty rare to see someone who spent more than 8 hours a day. But now that we know and recognize OCD more, you probably see it more often because people understand the condition more, and it's in the public eye. So measures change as our awareness of different conditions change, and so that's what leads to the necessity for revising things. There's another issue with the measure that I think is worth kind of raising for our attention. And Wayne, I know you'll appreciate this. This is not a criticism of the scale; it's more of an acknowledgement of its structure. So I'd mentioned there's subscales. You get actually more than one score when administering the Y-Bocs. You get an obsession score, a compulsion score, and then a total score. And a lot of drug trials and treatment trials use the total score as the way in which you get into a study. You need some minimum level of severity to qualify. And sometimes people come in, they have primarily obsessions and may not have a lot of compulsions. And so if you score really high on the obsession scale, but really low on the compulsion score, the total score doesn't look all that high. So let's say if you score, like you used yourself as an example, Kyle, if I may, you said like you scored like a 15 on the children's Y-Bocs when you were a teen. But if that 15, what if 12 of those points were on the obsession scale? Well, that's actually a lot, because the highest you could get on the original Y-Bocs is a 20 on the obsession scale, right? So sometimes I think that's something that's an important element that needs to be considered, is that there probably are some people out there who score really high on just half of the measure and may have quite serious and interfering symptoms, but they don't have a lot of compulsions. So people like with blasphemous thoughts and intrusive thoughts of harm and all kinds of other really difficult, uncontrollable ideas, but they have no compulsion at their disposal to stop it. Well, those people are suffering pretty badly. So anyway.
Well, and there's some folks that all they do is avoid, so they don't have to do compulsion, right? Folks with contamination, I just stay in my house, in my room all the time.
Right.
Everybody brings me food and stuff like that. That's really severe, but they might have a lower Y-Bocs score because it's all about the obsessions and very little.
So that I forgot that. That was another thing, another limitation we tried to address in the Y-Bocs too. We put more emphasis on avoidance and make sure that it's included in the in both the symptom checklist as well as in the target symptom list.
Right. But you had that as a supplemental item.
Yeah, I had it.
It was a supplemental.
We had a lot of
item
supplemental items.
Yeah.
I remember that there was a whole list of several supplemental. So actually, Matthew at 12:30.
Yeah, he
asked about that. So I'm glad we're covering that, right? Because avoidance is a huge part of OCD, and.
So you mentioned about the two subscales, for obsessions and compulsions, and I said, I had an interest in symmetry, but that wasn't the only reason. We wanted to be able to. We thought that we'd learn something about how OCD improves or changes with treatment, whatever that treatment is. So we were, for example, at one time I thought that maybe with a medication, it quiets the obsessions first. And so that you would see early on a reduction in the obsession subscore, and then only later, a reduction in compulsions. I haven't looked at this question in a very, very long time, but I'm not aware of, Dean or John, are you aware of any data from any trials with any intervention that one precedes the other? Because every time I've looked at this over the years, as people get better, you see it reflected in both their obsessions and compulsions by and large.
I agree with that. Yeah.
I'm not aware of any kind of let's say lagged analyses that you're describing. I'll say anecdotally in a general clinical practice kind of setting, the observation that I have, and the thing that I tell most clients is it's easier to do better than to feel better. And so my observation casually, and maybe more frequent assessment time points would reveal this, is that compulsions start to diminish faster, but the obsessions linger.
Yeah.
That's with behavior therapy.
Behavior therapy, right. This is not about medication, or DBS or other medical interventions, but that's been my observation.
Interesting.
Yeah. And it's an important thing for clinicians to know, because you can imagine the frustration from a client standpoint, right? They're like, Doc, I stopped washing my hands, but I can't help but keep thinking that I'm contaminated, right? And so knowing that and being able to urge the client on, no, if you stick with it, the contamination concerns will diminish. You just have to really stick with it. It takes a longer time for that to catch up, because otherwise it's a formula for potentially relapse.
In thinking about treatments like ACT, right? An ACT therapist wouldn't be concerned at all about, I got to think that through. They wouldn't be concerned about the time with obsessions. They would be concerned about interference, but they would say the interference is related more to compulsions. Mm-hmm. But an ACT therapist would be more concerned about reducing the compulsions, kind of like what you were saying, Dean, and maybe the obsessions goes down at some point, but that's not where the concern is.
Well, if we're going to get in the weeds about ACT for a second, I imagine my guess, and maybe there's an ACT clinician watching who's going to take great exception to what I'm about to say. They would say you could have as many obsessions as you want.
Yeah, right.
The idea is that they're not distressing.
Yeah.
Right.
That's interesting. Mm-hmm. So with DBS, my general deep brain stimulation, which would be I don't want to get into the details of it, but it's a neurosurgical intervention for severe treatment resistant OCD. Generally, I see the obsessions improve first. Although, again, I haven't done the lag analysis. This is just my clinical impression.
Yeah, that's interesting.
But that was the finding. The older medical intervention, I don't know how much it's done anymore, but were things like the capsulotomy and sigillotomy, these kind of brain surgeries that were lesioning out different areas of the brain that were considered responsible for obsessions and compulsions. That was also something that post-operatively patients were experiencing, was that there was a reduction in the obsessions or a reduction in the degree of distress, but the compulsions were
correct. It's not just the time. It's in fact, you're right. It's kind of a combination of decrease in time and then just not impacting the person as much. They don't bother them as much, and ergo they don't feel as strong a need to perform the compulsions.
Mm-hmm.
Yeah.
I'm gonna rein you guys in.
Right. We can just try to chit chat.
We're nerding out.
Right. Exactly. Yeah.
When you guys talked about avoidance a little bit, and when I was learning the Y-Bocs, I was told that this metric doesn't really get avoidance. Like, you have to be on the lookout for it because it's not going to pop up here. So how do you guys go about making sure you catch avoidance when administering the Y-Bocs 1?
Okay, well, it's like it's in the instructions.
Wayne's giving a blanket defense.
Yeah. One of the one of the things that there are a lot of people out there using kind of pirated or adulterated versions of the Y-Bocs, or diluted versions. that may be reduced to like the answer sheet rather than the instructions. So when we designed it, over the years, as we've made some improvements, we have careful instructions, including about making sure to incorporate avoidance. And what I ask about is, once I found out about, let's say they have contamination concerns, I find out, what in addition to the compulsions, what are the kinds of situations that you avoid or places you avoid? And that I agree, that's a very important component of the symptom severity. And in fact, as they avoid less, you may see compulsions increase because they're more in contact with the the stimuli that trigger their symptoms.
Yeah.
I mean, from my perspective, the issue with avoidance is one that I take into account for the measure. So I'll go for the assessment as per the instructions on the instrument. But then, if it's everyday clinical practice, then I would go beyond that, because I would recognize, and I think most clinicians would, that there's a functional analysis component that the measure probably just can't capture, because the way in which people avoid is so diverse. And I would start asking some additional questions post measurement. So the Y-Bocs would not be the last stop on the assessment of what constitutes avoidance, not to mention what are the full scope of the symptoms.
Yeah, because you need to know that in order to design your treatment.
Right, of course. Right.
Yeah.
Mm-hmm. And on the Y-Bocs too, Wayne, I was asked by the researcher who taught me how to use the Y-Bocs to ask you this. He's a big fan of the Y-Bocs too, and he doesn't know kind of like why it hasn't been adopted more widely in the research world. So what do you think some barriers are?
People are comfortable with the Y-Bocs 1, and I haven't marketed it. We haven't, we've kind of just slowly introduced it. So it may be in part our fault but I think people just get used to using a particular scale, and you do have to still add in one other. You still have to do the item 4 if you want to convert to the Y-Bocs 1. So I don't know. Maybe that's an obstacle. I don't know. What do you guys think?
I mean, I just think it's force of habit. I think it's just everybody thinks in terms of the original one, and that's just what was available and used in the studies. Those original studies, and it's hard to imagine like some sort of big shift.
Old dogs don't learn new tricks that easily.
Yeah,
right. I mean, that's it.
Yeah.
The new crop of researchers are going to have to be the ones that get inculcated to it.
Yeah.
So.
And there's just not as much treatment research on OCD.
Well, that's true. That's true. There's not as much happening.
You think that's because of NIMH not funding it? Or?
I think it's got something to do with it. I think so. Yeah.
Well, there's that, and there are other measures that the treatment research that's being done makes it more portable, and like there's a lot of work in like digital mental health, and so the Y-Bocs is not really as desirable tool for things like that, where the contact with the client is minimized, right? If it's based on an app or some other kind of platform where the idea is it's supposed to be more self-administered, well, then that includes what the measures might be. And suddenly now you're in really more self-report measure range.
No, I think that's a very good point, because we haven't talked about, how long does it take to administer. The first time is probably like 45 minutes. Because it's really, what you're doing is you're going through all the symptoms and trying to decide, are these bona fide symptoms of OCD, or some of the things that the patient has concerns about are really more what you'd see with generalized anxiety disorder, where they're worried about things that have nothing to do with OCD. So it takes a little while to educate yourself and the patient in terms of what the focus of treatment's going to be.
Yeah.
But so that you're right. I mean, it's kind of that's a lot of time, for a telehealth, for an app.
Right.
For sure.
Right.
Yeah.
Nobody's going to want to spend 45 minutes on an app, going through that. And you can't do it. You really need the clinician. And there are self-report versions of the Y-Bocs, and we're actually been working on doing a psychometric study of it. But still, at this point, I think that first session should be with the clinician.
Is a self-report Y-Bocs like practically the same instrument?
It is. It's just that it hasn't been well evaluated.
Yeah.
The anecdotal comment I remember from one of the early versions of the self-report model of the Y-Bocs that was out, it's like gotta be 25 years ago. Because generally scores are 2 to 3 points lower on the self-report than the clinician-administered. But that was just what someone told me in passing at a conference, who was a developer of the self-report one. So it's not like, this is not like hard and fast data. Like, oh yeah, hang your hat on that. 3 points lower. Just, like you add on 3. That's really probably what it is.
When I'm reading a study, like a treatment study, and they've used the self-report Y-Bocs, to me, that always, like, in terms of methodological quality, that kind of dings it down a couple of notches. There's something about someone who knows OCD giving that interview, making sure that it's standard across, patients, that isn't there when you have it, if it's online or they just give people a form to fill out. I wish people didn't start doing it. I can see why people do, but to me, the gold standard is the clinical.
I want to spend a moment on something that you just said, John. Someone who knows OCD giving the Y-Bocs and getting those ratings, that's an important point. Clinicians who have a lot of experience with the Y-Bocs, I think the way that their ratings come out is a reflection of that experience. And it's kind of what we see in other disciplines within psychiatry, right? So let's say, an example, a clinician is not that familiar with OCD, but they know about the Y-Bocs, they've talked to somebody, and they see a client in their office who has contamination fear. That clinician who hasn't seen a lot of people with OCD might rate that person as having quite severe symptoms. And then among the three of us, we'd go, yeah, that's like garden variety contamination. And they might not get that highest score. I think that's important to really pay attention to, because who you see and how much experience they have with it may be a reflection of the severity rating that you end up with.
And Wayne, I imagine the questions were designed to kind of mitigate that possibility, right?
Mitigate which possibility?
Like the possibility that someone who doesn't know too much about OCD could misgive the.
It is, but I think my expectation would be that the clinicians administering the scale would have seen cases of OCD before.
Right. There's sort of an expectation,
and that's what training does too. I mean, if you're going to do as we were talking about doing a clinical trial, you have to make sure that even if the raters haven't had a wealth of experience seeing patients with OCD, you need to spend time training them, showing them videos, and going over some of the finer points.
Yeah. Mm-hmm. And I thanks for highlight. That's kind of the underappreciated aspect that I was trying to highlight. Yeah. You can't just pick up the Y-Bocs and go, oh, I found it online, I can start giving it to my clients. You really can't. You really can't do that.
But you shouldn't do that.
Right. It's bad idea.
And certainly not in research.
Yeah.
There's a question at 1242 from my doppelganger 20, which was, I've always been a little fuzzy on ignoring obsessions and giving it less power versus avoiding those obsessions. It seems to get a little murky. If you guys want to address that concern.
That sounds like a question about item 4.
Yeah.
What do you think?
Well, the question was raised like 10 minutes ago, so I think we were on item 4 10 minutes ago. Mm-hmm. So the nuance on this for my doppelganger 20 and I don't know if this is the right answer or this is clinically how I address this with people. Giving it less power is basically where you'd say to yourself, go ahead, allow the thought to be there, as opposed to avoiding it. Avoiding it means that you're going to engage in some kind of strategy that would diminish its presence. Like you would actually deliberately and purposefully try to not have the obsession. That's usually not a great plan. But if you basically tell yourself, I can have this thought, there's nothing wrong with this thought, having the thought and it not translating to action is fine. then that would be the way that it is given less power. I don't know if that comports with what you guys would say, John.
That sounds like a good answer.
Yeah, I agree with that.
Thanks.
And you said it so authoritatively, Dean.
Yeah.
That's the main thing, is that you say it with authority. I find that I live my life best by just saying everything with authority, even when I'm like profoundly wrong.
No, someone said great analogy.
Yeah, Matthew.
You're on the right track.
Okay, thank you.
Probably.
I hope so.
I also wanted to ask you guys, I know there's other metrics or ways to measure OCD severity, like I think the DOCS is one, that aren't the Y-Bocs. And in what situations would you go for those? And like, how are they different than the Y-Bocs?
Yeah, well, so I can speak to the docs as the person who worked on developing that. It's different in that the docs so this is the dimensional obsessive compulsive scale, which is a self-report version, meant to be a self-report version. And that is to some extent inspired by the Y-Bocs, but it measures instead of having the checklist at the beginning of the Y-Bocs, this is meant to go a little faster. And so there are 4 subscales of the docs. One that kind of map onto the 4 most replicated like domains of OCD symptoms. So you have a contamination subscale, a responsibility for harm subscale, a symmetry subscale, and then like a taboo, unwanted intrusive thought subscale. And so that's one of the differences. The other main difference is that on the docs, it combines obsessions and compulsions together, because some of the studies looking at the Y-Bocs have found that in those factor analyses that Dean was talking about, that the obsessions and compulsions, some of those obsessions and compulsions items load together as if obsessions and compulsions, you shouldn't try to tease them apart. They're kind of one and the same. And it makes sense if compulsions are responses to obsessions. So on the docs, we ask about obsessions and compulsions related to contamination in the same item. But it very much is inspired by a lot of the, how much time does this take up? How much does it interfere? There is an avoidance question on that, but that's a different. So they're 2 very different scales, and they do not correlate especially strongly with one another.
Is that surprising?
No, it's not, because the great thing about the Y-Bocs is you go through the checklist in the beginning, and then you tailor the 10 items on the Y-Bocs that you ask, the severity items, you tailor that to the person's specific obsessional fears.
Okay.
The docs doesn't do that as carefully. The docs is not as sensitive. It's measuring different stuff.
The concept that John is talking about in psychology that we refer to, you want measures that assess the same area of functioning. So let's say 2 different measures of OCD. You expect them to correlate fairly well, but not perfectly. Because if they correlate perfectly, you ask the question, well, why do I need this other measure? The other measure should be doing something unique relative to the other one. That's why when a good comprehensive assessment, you might give more than one measure, because it gives a fuller and more complete picture of what the symptom presentation is for the client. So the docs and the Y-Bocs together, that's a good assessment set.
Yeah, we've been using that for our DBS studies.
Yeah.
Because you get a lot of different information.
You get different information.
Yeah, I'm sorry, I missed in all the words. What specifically would I be giving the docs for to see? Like, what additional information would I be getting from it?
Well, you can get information specifically in a quicker way. You can get information about those 4 domains, and you can get a profile. Okay. This person is high on contamination, low on symmetry, which in the Y-Bocs, that wouldn't necessarily give you that.
Mm-hmm. You could kind of fashion the Y-Bocs to get that information, right? You could see the symptom checklist. They have contamination concerns, then ask about contamination concerns. It would take longer.
Yeah, but you would then have to ask separate questions.
Yeah.
About
you have to go through the Y-Bocs multiple times.
That would take a lot of work.
It would just take too long.
Yeah.
It's not economical.
And what other measures of OCD severity are there, if any?
Well, there's the obsessive compulsive inventory. John and I, along with our colleague Amitai Abramowitz, we've been working on that for the last couple of years. And we have now a 12-item version of that scale. That gets at also symptoms of, it's a fast measure that can be administered that assesses washing concerns and contamination, checking, intrusive thoughts. and I don't have it in front of me. I'm blanking on all the factors.
Symmetry
and ordering, and one more factor.
Yeah.
Did I mention checking? I must have mentioned checking.
Yeah. Check.
Probably like blasphemous thoughts, or I know that's not the name of the factor, but it's something like that.
And for similar reasons, it's not all that strongly correlated with
Right.
the Y-Bocs,
Right.
because the Y-Bocs is, you're focusing in on a particular type of, obsession and compulsion, whereas the OCI 12, you're asking about all sorts of different ones. So someone who could have really severe OCD and have a really high Y-Box score because their contamination symptoms are off the charts.
Mhm.
But then on the OCI, they're going to have high contamination scores. That's only 3 items. And then the other, 9 items might be really low if they don't have any checking or symmetry or stuff like that. So it's just different ways of getting at it.
Okay. We're at an hour, and I want to be respectful of everyone's time, but this was interesting, and it was very fun to see Jon nerd out. I don't normally get to see him nerd out like that.
We see it every month.
Not like
What are you
this.
talking
This
about?
was crazy.
Well, this is we got the Wayne Goodman with us.
Yeah, really.
Really cool.
And Dr. McKay. I mean, that
And
man
the
knows your front and
Dr.
back.
I mean, I just, I'm just happy to be here.
Well, thank you guys both for being
Thanks
here.
for having me.
Yeah, thanks for inviting me.
Good to see you guys.
There's OCD walks going on around the country, I think I'm supposed to say. So go look up one in your local area. But yeah, that's enough for us for the hour.
Thanks very much. Nice meeting you.
Great to see you guys. Good to see you.